My name's Lance Liberty, and I'm the presenter for today's educational health presentation sponsored by Joint Regeneration and Anti-Aging, located in Noonan, Georgia. You can schedule an appointment at their facility by calling 770-343-4465. And we're going to repeat that information at the end of today's presentation as well. So before we begin, I'd like to discuss the purpose of today's presentation. First and foremost, it's to provide help. We're going to be discussing non-surgical treatment options for osteoarthritis of the knee and shoulder and other joints today that may work for you, even if oral NSAIDs like ibuprofen, cortisone injections, surgical interventions, physical therapy, or other treatments have failed to provide relief in the past. But almost most importantly is hope. So many people, when they're suffering from a condition like this, feel like they're in a corner and they have no options and no one else has walked the same path as them. And I felt that way almost 2 decades ago when I was told I was needed joint replacement surgery after suffering a high school football injury. I had torn a few major ligaments in my right knee blocking on a kick return my sophomore year, and I had it surgically repaired. After that surgical repair, I was able to walk and do normal activities. I was not able to return to sports, but I was quote unquote normal, if you would. A couple of years after that repair, though, the repair failed. And I went and got an MRI because I could no longer bend my knee. And I was bone on bone contact medially on the inside of my knee, suffering from early onset osteoarthritis. I was told by my radiologist and my orthopedic surgeon that surgery was my only option and that nothing else could work for me. Luckily, though, I was working with a chiropractor at the time, of all people, whose father was a doctor of osteopathy. And he was injecting this medication called Hyalgin at a orthopedic clinic that he was working for in northern New Jersey and Manhattan. And his son, the chiropractor, told me about it and invited me to fly up and try the procedure. So I flew from Tampa, Florida up to southern New Jersey, and I had this procedure done. And after the first injection, I had some reduction of pain. By the third injection, I was able to move the joint normally again. By the end of the 5 injections, not only did I have no pain, but I could run and jump and play basketball and do things I hadn't done in years. So it was very, very miraculous. But it got me thinking, why didn't my orthopedic surgeon, my radiologist, my primary care doctor, any of these people that I was counting on back home in Florida, why didn't they tell me about this? How come they didn't know that this treatment existed? Why were they so gung-ho on just pushing me towards surgery and repeating over and over that I was bone on bone and nothing could work for me? And I wondered how many other people were being told similar things. And I actually was able to get that doctor who injected my knee to partner with his son, the chiropractor, and open a clinic in southern New Jersey that became the beta site for where we developed the Advanced Arthritis Relief Protocol. It's a non-surgical approach to your disease that is being used in over 200 clinics in 38 states nationally and has been used in that scope for the past decade with tens of thousands, maybe even hundreds of thousands of patients successfully treated. So before we get into the specifics of osteoarthritis, let's talk about knee pain in general. It's one of the most common conditions affecting Americans behind only back pain. According to the Center for Disease Control, over 700,000 people had knee replacement surgeries in 2013. Last year, there were over 1 million people that had knee replacement surgeries. So there's been a continued growth in the number of people that are being told they need surgery and eventually receiving surgery as the treatment for their pain and loss of function, sometimes with good results and sometimes without. Today's goal is to discuss your options that you can use to delay or avoid knee replacement surgery that are covered by insurance, that are less costly, that are less risky, and that by many insurances are actually required to be tried and failed prior to that surgery being covered anyway. So more than 40 million people suffer from knee pain at any given moment in the United States. It results in hundreds of millions of visits to doctors' offices and billions of dollars in expenses for co-payments and co-insurance and medical bills and surgeries and so forth. Osteoarthritis is the most common cause of knee pain. It's a degenerative condition that affects the bones and the cartilage of the joint and can result in pain, swelling, and loss of motion of the joints. Arthritis cases are growing pretty rapidly. Between 1995 and 2020, there was almost a doubling of the people that suffer from osteoarthritis. There's expected to be another 50% growth in the number of people diagnosed in the United States with osteoarthritis by 2030. So every 15 to 20 years, osteoarthritis cases are doubling in the United States because we're living longer, we're staying more active, our population is becoming slightly older demographically speaking, And osteoarthritis of all forms of arthritis is by far the most common type. You might think by watching television and seeing TV commercials for Enbrel and the other products for rheumatoid arthritis that affects the hands and fingers that it's the most common, but osteoarthritis is almost 10 times more prevalent than rheumatoid arthritis. Yet you don't see as much money spent on television commercials and advertisements for osteoarthritis. Well, it's because there's no pill you can take for it. There's no pharmaceutical solution for it. So all big pharma's dollars are going towards other things like rheumatoid arthritis or psoriatic arthritis that they can give you a pill or a intravenous infusion for, not osteoarthritis, which can be solved a little simpler and with much less costly means. So osteoarthritis, in addition to being the most common form of arthritis, is oftentimes referred to as wear and tear arthritis because you think of it as a mechanical disease. It's the bones, it's the joint, it's the structure of movement and the hinge, if you will, that's failing. But before those hard structures start failing, there's a fluid-filled capsule called the synovium that begins to no longer act properly. It'll have less fluid, thinner fluid. It'll stop providing cushioning, lubricating, and shock absorbing properties that it does naturally. So osteoarthritis actually starts off as a drying problem when that fluid is diminished in both volume and consistency. We're going to talk today about how we can actually fix that fluid and stop the root cause that created all the other problems that you are dealing with your osteoarthritis. So why the knee? Well, it's the most commonly used joint in our body. We've been walking on it since we were about 1 year old. It bears the majority of the weight of our body, roughly 80%. It's pretty at risk to injury. Big injuries like what I had playing sports, or if you're in a car accident and you hit the steering wheel or the dashboard, if you fall and hit your knee. But even little micro traumas like banging your knee into the coffee table over an extended period of time can damage the synovicytes, the little glands that produce that synovial fluid, and help to speed up the rate at which you might suffer from osteoarthritis. The older you are, the more likely you are to have osteoarthritis because you're using the joint more. I'm more of the exception, not the rule. I got it young because of that traumatic injury. Obesity, the heavier we are, the more load we put on the joint. And deformity. There is something called a varus or valgus deformity where the knee becomes what you might talk to as knock-kneed or bow-legged. This misalignment of the joint greatly speeds up the rate at which the cartilage wears away and the dysfunction of the joint itself. Now, your knees can wear out unevenly if they have that varus or valgus deformity or knock-kneed or bow-legged. And I like to use automotive analogies because they're very relevant to what we're discussing here mechanically in the body. So if you've ever had a car where the alignment goes bad, you'll see that the tires will wear out unevenly. One side will wear tread pattern faster than the other. And if you don't do something about it and fix that alignment, eventually it'll lead to a blowout. The knee is not very indifferent than that. When you have these misalignments and this uneven load, that compartment starts to fail pretty quickly. And typically you tend to see osteoarthritis present in that fashion where one side of the knee is going bad faster than the other that remains relatively normal. So if we look at this anatomical drawing of the joint, this triangular shaped object here is your patella or your kneecap. And it's designed to glide over the femur bone in the channel between these two round mounds of bone and cartilage there called the femoral condyles. This shiny white substance you see here that covers the end plates of the bone is called hyaline or articular cartilage. It's a hard cartilage similar to the consistency of your fingernail. That's your body's last line of defense if the joint starts to break down. That hard substance protects the underlying nerves and blood vessels that wrap around the outside of the bone. In between the two bones, you've got your meniscal cartilage, which is a soft cartilage, and the primary shock absorber and impact resistant structure in your knee that is utilized if the synovial fluid, that dense gel-like fluid we've been talking about, starts to wear away or become more thin. That is actually your first line of defense. So those are the three structures that are designed to keep your knee in stasis and operating normally. Now, your knee has a fluid-filled capsule around it. This capsule is called the synovium. And inside the synovial membrane, there are these little glands called synovicytes, and they excrete the fluid that fills this capsule, which is made of, amongst other things, hyaluronic acid. Hyaluronic acid is a very special substance. It's actually called non-Newtonian because it doesn't follow the laws of physics. Meaning, typically, if you have a fluid like water and you launch a boat into a body of water like a lake, it'll displace the water and the boat will float. Well, hyaluronic acid doesn't displace it; it resists any type of force that's applied to it. So, if you were to drain that lake of water and refill it with hyaluronic acid and try to launch that boat, it would tip over because as you try to move the hyaluronic acid out of the way, it actually becomes more dense and resists that compression. So it's the hyaluronic acid that gives your joint fluid this special property that allows it to act as a shock absorber and a cushioning and protective layer for the joint. As that hyaluronic acid becomes less prevalent in the joint, it is no longer able to lubricate and cushion or act like a shock absorber the way that it used to. The fluid becomes more thin, it loses that thick structural property. And as the bones move closer together, that creates friction, which wears away and damages the cartilage. Here's a drawing of a more advanced stage of arthritis where pieces of the cartilage and bone have worn away because the joint has become bone on bone, as this fluid was no longer able to support the joint, and the joint wore through the soft cartilage, the meniscus, and the hard cartilage, the hyaline cartilage, eventually damaging the underlying bone itself. If you've ever been walking or bending, or getting up from seated or stepping out of your car and you felt something that felt like a latch catch on your knee, and then all of a sudden it released, you're probably experiencing the feeling and the sensation of one of those loose bodies of bone or cartilage getting caught as you go through that range of motion. And if you've worn through this cartilage that covers the bones, if you ever feel a sharp electrical pain that goes down your calf into your foot or up your thigh into your buttock or your low back, those can be the nerve endings that wrap the bone that have become exposed as the cartilage has worn away. Because if you've ever seen a bone, whether it's a human bone or an animal bone in a museum or a zoo, they're not perfectly smooth. They're covered in what looks like a bunch of little channels that might have been carved out by like a river valley, if you will. And those channels are full of blood vessels and nerve endings. So when you wear through first the soft cartilage, the meniscus, and then the hard cartilage, the hyaline cartilage, it can expose those underlying nerves. And if you ever chipped a tooth and had a nerve exposed, you know what that feels like. It's got that very sharp electrical pain that can be quite debilitating. So if you've got a sharp shooting pain, you've probably worn through that hyaline articular cartilage. That is usually why you're experiencing that symptom. But that's okay. Everything we've discussed so far can be reversed. The body has an amazing ability to heal itself if you put it in the right environment to do so. So I want to show you some real x-rays of actual patients. These x-rays were shared with us from one of our facilities in Orlando, Florida. And before we look at the bad knee x-rays, we want to look at a normal knee. It's sometimes hard to know what's wrong if you don't know what right looks like. And I know when I got my MRI, they slapped mine up on screen and told me how bad I was and how I was bone on bone, but I had no idea what normal looked like. So while they were telling me I had no options, I didn't really fully understand why I didn't have any options. So I think it's important to look at what a normal knee looks like. It'll help you better understand when you get your x-ray, if you come in for your risk-free consultation, what you're looking at and how you compare to normal. And if you've already had an x-ray and MRI, maybe this will help you better understand what you've seen in the past. So in a normal x-ray, we take two views when you come into the facility for your consultation. One is called AP, anterior posterior, or front to back, and the other is lateral, a side view. So in the front to back view, this guitar pick-like looking shape is your patella or your kneecap. It should be nice and centered in between these femoral condyles running in that channel. A lot like a sliding glass door, when it's on the channel, it glides very smoothly and easily, but if it comes out of that channel, it grinds and becomes difficult to move. Your kneecap is not much different, and if that process happens, it's called patellofemoral arthritis. You can see the thick hyaline cartilage here covering the femur, the thigh bone, and also the top of the tibia, the shin bone. All this black space that you see in between the two bones, and x-ray image is hard structures, not soft structures. So you can't see the meniscus or the synovial fluid, it shows up black. That's what's keeping this space open here, the combination of those structures. In a normal knee, you should kind of be able to trace the outline edges of the bones, and they should pretty much line up with the other edge of the bone that it's gliding past in normal function. And right in the middle, you've got your tibial spines, which should be smooth and kind of looking like the Appalachian Mountains, not sharp and pointy like the Rocky Mountains. On the side view, what we're looking for is joint space between your patella and your femur, your thigh bone. There should be a little bit of space there, which you can see this black line here. That's normal. If it's resting on top of your femur, we know that you're suffering not just from osteoarthritis, but also patellofemoral arthritis. So let's look at some actual knees. This is Kellgren-Lawrence grade 1. There's a grading scale for osteoarthritis. Oftentimes I find that the orthopedists and radiologists will just use general terms like bone on bone without getting into the specific stage that you're at in the disease. So I want to explain those stages. They play a big role in how likely this treatment is to work for you and what your treatment options should be. So starting with early osteoarthritis, there's just a small loss of joint space on the inside of the knee here on this particular example. And you can see the patella of the kneecap is slightly out of alignment. The femur bone is kind of moved inward, the kneecap a little outward. Typically at this stage, you're not even feeling any pain or dysfunction. You really haven't gotten to a point where that kicked in. So most of the people that we see are in grade 2 or higher. In grade 2, you start to see little osteophytes or bone spurs form. You can see some thickening of the tibia. The more white and bright something is on an x-ray, the denser it is. So as the joint space starts to collapse, the body tries to build more thick bone to handle the compression and the force of these bones now colliding and grinding together. Whereas in a normal joint, our bones glide next to each other. They never touch. We move our fingers, our toes, our elbow, our knee, etc. These bones are not like a hinge on a door that are attached and constantly touching each other. They actually are meant to glide next to each other. Here we can also see the tibial spines becoming sharp and pointy like the Rockies, no longer smooth and even like the Appalachian Mountains on the East Coast. And that's another sign of osteoarthritis. At this stage, you're probably getting soreness, maybe a little swelling, difficulty with certain activities like yard work, cooking or cleaning. Basically, your knee is not what it used to be. At this stage, you start to notice some loss of function. When you get to grade 3 and grade 4, that's when you start to get the more severe symptoms, and maybe you require a cane or a walker or a wheelchair to get around and ambulate. So in grade 3 osteoarthritis, we can see that the femur bone, the thigh bone, is much more out of alignment. It's moved much more inward versus the tibia. You can see those bone spurs are a little larger and easier to see. Those tibial spines have been worn away, the kneecap further out of alignment. In grade 4, we can see that bone spur even larger, the kneecap even further out of alignment, and starting to get some bone-on-bone contact here. Now, even if you've been told you're bone-on-bone, that does not mean that surgery is your only option and that the Advanced Arthritis Relief Protocol won't work for you. In fact, I'm going to show you an x-ray of a real patient who was in a wheelchair and bone-on-bone that had a great outcome and was able to return to walking after 2 rounds of treatment. So even in those more severe cases, this treatment option might still be on the table for you to delay or avoid knee replacement.
Millions of Americans suffer from the debilitating effects of chronic knee pain, arthritis, and osteoarthritis. If you are one of them, remember, no matter what you've been told, drugs, steroids, and knee replacement surgery are not your only options anymore. Call the number on your screen right now because you could qualify for a remarkable breakthrough treatment that helps relieve your knee pain without pills or surgery. This remarkable and innovative treatment replenishes the lubricant in your joints that may be lost due to age or injury. This all-natural, FDA-approved product is introduced into the knee, creating a comfortable cushioning layer that protects and lubricates the joint, allowing you to enjoy smooth, pain-free movement once more. This promising treatment, considered to be the first major breakthrough in years for relieving knee pain, is covered by most insurance plans, including Medicare. If you just can't deal with your knee pain any longer, then call the number on your screen right now to see if you qualify for this emerging knee pain treatment. This call could bring you the relief you need to change your life and get you back on your feet.
Now, if you do wind up in a situation where knee replacement is truly your only option and nothing else works, I want you to remember this image. It's called a partial knee replacement. On all the x-rays I showed you, if I just go back one slide, you'll notice that one side of the knee was much worse than the other. The other side stayed more normal, or at least had some space remaining. So if half of the knee is good and the other half is bad, why would you replace the whole thing? Well, that's the idea behind a partial knee replacement. It changes out only the portion that has failed. And the reason I am such a fan of partial knee replacements is that when they do a partial knee replacement, they leave the synovial capsule intact, that membrane that surrounds the knee. So the body's natural cushioning fluid is still present in you if you've had a partial. And if you have a partial knee replacement and your symptoms start to come back or get worse, you can have injections like the ones we're going to talk about today. You don't have to go back in for surgery as your only option. When you've had a total knee replacement, which I'll show a little bit later, that fluid filled capsule is actually removed from your body. And then you're stuck basically with only surgical options to consider. And that's really where the Joint Regeneration and Anti-Aging Center of Noonan comes in. If you've tried oral NSAIDs, cortisone injections, physical therapy, arthroscopic surgeries, and those things haven't worked to provide relief and get you back to normal function, before you move on to surgery and having replacement of your natural body parts, this video guided injection of hyaluronic acid to replenish the synovial capsule, a special unloading knee brace, and physical therapy and home exercise protocols to help your ligaments go back into a nice taut fashion, bring the knee back into alignment, strengthen the muscles, get you back to normal function. And these are very easy activities, by the way. It's not like squats and leg presses and heavy duty stuff at the gym. Some of these activities are not even weight bearing. It's just putting your knee through a range of motion, but helping to retrain it to act normally. And these results can be quick in a matter of weeks, significant improvements, and they can last for years to delay or avoid knee replacement. Also, if you're more severe and you have worn away your meniscal cartilage or your hyaline cartilage, we have the ability to look at regenerative medicine techniques like platelet-rich plasma or mesenchymal stem cells to stimulate the growth of the meniscal soft cartilage or the hyaline hard cartilage of the knee. So what about these things that you might have tried and failed previously, like pain medication? Well, hydrocodone, Vicodin, Tramadol, all these prescription scheduled drugs, we all know about their risk factors for addiction. You see that if you watch the news with the opioid epidemic that's going on in our country today. Almost all those people that are using illegal opioids started with a legal prescription because they had an injury or a surgery. And unfortunately, these medications are very strong. They call them opiates because they are derived from the same poppy seed that produces opium, highly addictive substance. So it's really easy for people to misuse these medications. But beyond the misuse of the medications, even just using them normally can cause problems with constipation, respiration, heart function. And that's because when you use an opioid, it's slowing down the speed at which your nerves fire. So it's not fixing the cause of the pain, but it's making it more difficult for your body to transmit and receive that pain signal. Well, as it slows down those nerves that are transmitting pain, it also slows down all the other nerves and functions in the body too. Your GI system doesn't digest as well as it used to. Your brain's not firing as fast as it used to with all those axons and neurons. That's why you might feel foggy or less sharp mentally when you're using pain medications. So it's those side effects and risk factors that really make painkillers not a good option for a chronic disease like this. If you had a short-term injury, they're fine to help you get a little relief while you're recovering, but osteoarthritis is not going to go away. It's a semi-permanent disease. You can manage it, but you can't get rid of it. You don't need taking painkillers for the rest of your life. So if you don't be using those prescription medications, what about the over-the-counter medications like Tylenol, which is acetaminophen, Advil, which is ibuprofen, or Aleve, which is sodium naproxen? These medications all work to stop inflammation, to stop swelling, to stop effusions, etc. And they can be great at masking the symptoms of your condition short term. But again, long-term use is very risky. And where I learned that personally was when our daughter was very young. She's our only child. She was sick, had a fever. We rushed her to the emergency room as new parents. We were very scared, didn't know what to do. And the doctor tells us, go buy some Tylenol and some Motrin. And every 4 hours, give your daughter Tylenol. And then 4 hours later, give her Motrin. And I go, well, why are we going to use both? And he goes, well, if you switch back and forth between the two, you can keep the amount of active ingredient down, and it's much less risky for the child. And then you don't have to wait as long for another dose and so forth. So I'm like, okay, go to the pharmacy, buy these medications. And before I give them to my daughter, I want to make sure I'm doing everything perfectly. So where it's got that little peel here on the edge of the label to get all the instructions, I peel it, scroll it out, read the whole thing, right? And I saw something really interesting that I was never aware of. It said that you're not supposed to use those medicines for more than 7 consecutive days. And not only was that a new piece of information, but I had been taking Advil 6 to 8 pills a day for months, probably the better part of a year when I was dealing with my knee pain before I had these injections done while I was waiting for the surgery I was supposed to have. And didn't realize that I was really grossly misusing the medications off of their labeling guidelines. And that's where these medications become risky. Tylenol doesn't kill anybody when you use it like you're supposed to. It's extremely safe. They have baby Tylenol for little infant newborns, right? But when you use it over an extended period of time, that's when it can start to really damage the organ systems in the body, the kidney, the liver. And that's why you see over 30,000 people a year in the United States that die from Tylenol. It's not that Tylenol is dangerous, it's that they overused it and they misused it. So we don't want to be using that stuff every day for an extended period of time either. So if you don't want to be using all these pills over the counter or prescription, looks like surgery is your only option. Not anymore. Now, if you ever do look at surgery, some of the considerations with surgery is these artificial joints are not custom made for each one of you, and they don't fit everyone perfectly. In the x-ray I'm going to show you of a total knee replacement, you'll see that the bone's kind of hanging outside the edges of the knee replacement. The knee replacement was too small. It wasn't the right size for that patient. That's normal. And they don't last forever. That's not often described to you before you get this procedure done. The average knee replacement lasts for about 8 to 12 years. It's going to vary based upon how active you are, how much you weigh, and other factors. But if you're in your 50s or 60s, you definitely want to try and delay the surgery as long as possible, because you'll probably wind up needing a revision surgery at some point in your life. As you get later in life, surgery might make a little more sense because you're not likely to outlive the hardware, if you will. There's also a long and strenuous recovery, and the results aren't the greatest. After 2 years, roughly half of all patients that have knee replacement surgery have the pain return. And then there's the risk factors with anesthesia. So I like to simplify the outcome of surgery into 4 equal categories. One where it's the best thing they ever did. Their pain's gone, their function's back. They're very glad they had their knee replaced. Another quarter where the pain is improved. It's not as bad as it used to be. Their function's a little better, but it's not 100% recovery. Then there's the folks that have it done and it doesn't change much at all. But there are also people that have surgery done and the pain gets worse. Now, I'm not just talking about the people that have post-operative infections like MRSA and staph, where their pain's associated with the infection and that has to be redone or cleaned or treated, but just regular, uncomplicated surgeries. But the scar tissue from the cutting, from the anchoring of the artificial hardware, from the trauma of that, from the physical therapy and the recovery period, that pain actually being equal or greater than the pain that they were experiencing in the first place before they had the knee replacement performed. Now here's your partial knee replacement image again, and here's your total. So in a total, they cut off the top of the tibia, the shin bone, they cap the top of the femur, and you've now got a metal or plastic substance here that replaces your normal bone and cartilage and tissue. And in these total knee replacements, they're going to discard that synovial capsule. So there's no fluid-filled structure to cushion or lubricate that hardware anymore. It's just going to slowly wear away over time. And then lastly, the dangers of anesthesia. Now, we all know about that minor risk of not waking up, but there's something much more common called postoperative cognitive dysfunction, or POCD. And this basically has to deal with the fact that we all have different metabolisms. I'm sure you've all got that friend that no matter what they eat, they always stay skinny, right? And then maybe you are, or someone who's a little heavier. No matter how much you diet or exercise, it's hard to lose weight. Well, it's because we all have different metabolisms, right? And that's why some people during anesthesia will wake up early if they have a fast metabolism. And then other people with slower metabolism, sometimes it might take up to a half a year for them to get all of that anesthesia out of their system. So it can leave you feeling foggy and groggy and having these Alzheimer and dementia-like symptoms, and also put you at increased risk for stroke and other cerebrovascular events because of that latent medication that's still in your system. So we're here to help you avoid these drug surgeries and complications. There is a better way. So if osteoarthritis is a drying problem, let's talk about that for a second, because it's not just the fluid itself and how it supports the joint and cushions and lubricates it and acts as a shock absorber, but that fluid also plays a really important role in the health and function of the cartilage. A great science experiment for this, if you want to do it at home, is to take a sponge, get it soaking wet, and try and rip it in half. It's going to be very frustrating. No matter how hard you try, you're going to have a hard time even tearing this sponge just a little. You'd probably be unable to, even if you're a big, strong person, because when the sponge is full of fluid, that fluid makes the tissue of the sponge more elastic, more resilient, gives it more strength. Now let that sponge sit on the side of your sink for 2 or 3 days and dry out a little bit to where it's still moist, but it's no longer soaking wet and dripping wet. Now pick it up and try and rip it. You'll probably be able to tear it. You might even be able to put a big tear in it. If you scrunch it up, it's not going to spring back to its original shape as quickly or easily as it did when it was soaking wet. Now let it dry out for 2 or 3 more days. And you're not even going to have to try and rip it. Just put it in the palm of your hand, close your hand, and it'll crumble like dust. Well, the sponge is no different than when it was soaking wet. It's the same structure. But the lack of that fluid, the lack of that hydration, it lost all of its structural integrity and its strength and its resilience and its ability to rebound and maintain its shape, because that fluid plays an important role in keeping it healthy and functional as it's meant to be. Your meniscal cartilage is very, very similar to this analogy. With enough joint fluid and hydration and lubrication, it's very difficult to damage it. If you look at athletes that are in peak shape, they take all types of hits and all types of movements, and that cartilage is usually fine. It's only when they get a really extreme impact from a weird angle like the side that you see these structures fail, because they're designed with a grain to move front to back. So it's a very strong substance. It doesn't break on its own, but without hydration, it makes it much easier to fail. So when we look at the synovial fluid, it's not only providing structural integrity to that meniscus, but it's also physically keeping spacing between your thigh bone and your shin bone, your femur and your tibia. But as it changes from this thick gel-like fluid to a more water-like and thin consistency, it allows those bones to move together and create more friction, which starts to break down and wear away the cartilage and the other capsule and the other structures of the knee. So wouldn't it make sense to just fill that joint capsule back up again with a nice thick fluid? This is not a trick question. This is exactly what we're talking about here today. It's called joint lubrication. And we're very literally replenishing the hyaluronic acid that you're deficient in inside your joint. And this helps to stimulate that joint to make normal, natural synovial fluid and hyaluronic acid on its own. And it's a lot different than steroids and other injections. You see, steroids or cortisone are anti-inflammatories. They reduce inflammation. So if you, hit your knee and it gets swollen, cortisone might be a good treatment for that acute symptom. But if you have osteoarthritis over months and years, it's not really a good option, because how cortisone works and how corticosteroids work is they dry things up. If you've ever had a sinus infection or a respiratory infection, you've been coughing and had a lot of mucus, you might go to the doctor and they give you prednisone or another steroid to take orally. And after you take that for a day or two, everything's dried up. You no longer have that congestion. So that's how it works. Well, if you've got a drying problem, wouldn't drying it out further make it worse? Kind of commonsensical, right? And it's not just the fact that it's going to make your osteoarthritis worse over time, but there's the other risk factors associated with it. If you've ever had a cortisone injection, it probably stung or burned. It's because it's very acidic. And in the area where you injected it, actually will break down bone, up to 8% loss of bone in 4 months. So if you have osteoporosis, it can make it worse. Corticosteroids are also, their full name is glucocorticosteroids. They're derived from a sugar-based molecule that's actually found in a sweet potato that grows in the South American Amazonian rainforest. So when our body breaks this down, it actually causes our blood sugar to spike after we have these injections. That's why if you've ever had cortisone, you might have a lot of energy later in the day after you had it done, because your body got a big jolt of sugar. And if you have diabetes, it can make it more risky. And if you use steroids over an extended period of time, it can even increase your risk factors of things like developing cataracts, because the eye has a dense amount of blood vessels in there and a very strong blood supply. So cortisone has all these bad side effects and also weakens your immune system, which especially in a time like now, where we're all trying to stay safe from COVID-19, can make it more difficult for you to resist infection or other diseases. So for all these reasons, cortisone might be a short-term benefit to reduce pain, but a long-term risk that's going to make your osteoarthritis a lot worse. In fact, the Food and Drug Administration actually says that you're not supposed to use a corticosteroid injection more than 3 times in any single body structure or area because of those risk factors associated with it. And there's some new clinical research that's been published in the past few months that actually goes even a step further and says that cortisone is not an effective treatment at all for osteoarthritis and should not be used. So the insurance guidelines surrounding this are probably going to change real soon because the clinical literature and the science is starting to show that cortisone is not a good treatment for osteoarthritis at all. It actually makes it worse. Little food for thought there. So better idea, let's change the joint oil, also known as viscosupplementation. Now, not all viscosupplements are made equal. I had Hyalgin, which was the first FDA-approved product in 1996. It was actually the first viscosupplement made in the world, first used in humans in 1985, and originally developed and used in horses, race horses that had arthritis in 1982 back in Italy, where it was discovered. Now, since then, there's been a couple dozen other products that have been manufactured and approved by the FDA for use here in the United States. One of the newer medications is called Genvisc 850, and that's the one we most commonly use at this point in time. But before I get into the specifics of the medication and how we deliver it, I'd like to play a brief little 2-minute video that actually shows the procedure being performed and can give you a visual of our approach and why the Advanced Arthritis Relief Protocol might work if other injections, even of other viscosupplements, have not worked for you in the past.
Osteoarthritis, also known as degenerative joint disease, is the most common type of arthritis. With osteoarthritis, the surface layer of the cartilage breaks down and wears away. This allows the bones under the cartilage to rub together, resulting in pain, swelling, and loss of motion in the joint. Although in some people it progresses quickly, in most individuals, joint damage develops gradually over years. Viscosupplementation therapy is a non-surgical outpatient procedure by which a pain relief medication called Suparts is injected into the knee joint. This medication mimics the body's synovial fluid of the knee that lubricates the cartilage. Suparts will help the knee to move smoothly, reducing or relieving the pain of osteoarthritis. In preparation for the injection, the physician sterilizes the knee and administers a local anesthetic. The physician positions an imaging device called a fluoroscope over the knee. The fluoroscope will display a moving X-ray of the inside of the knee that will ensure the Suparts reaches the joint space. The physician carefully guides a needle to the joint space. The physician confirms the placement into the knee joint with an injection of contrast dye. The contrast dye is clearly visible on the fluoroscope image. If the dye pools in the soft tissue at the front of the knee, the physician will adjust the depth and angle of needle placement until the joint capsule of the knee is reached. When the contrast dye flows through the joint capsule, the physician knows they are ready to inject the Suparts. While leaving the needle in position, the physician removes the contrast dye syringe and replaces it with a syringe filled with Suparts. The physician injects the Suparts into the joint space within the knee. The Suparts will bond with the synovial fluid inside the joint, cushioning and lubricating the joint. When the injection is complete, the physician removes the needle and bandages the knee. Ice is then applied to reduce swelling. Suparts is administered in a series of 5 injections 1 week apart. Pain relief can be immediate and has been shown to last for 6 months or longer. In addition to the Suparts injections, knee bracing and physical therapy are utilized to enhance the effects of the medication.
So hopefully that helped give you a little better
Osteo-
understanding of the Advanced Arthritis Relief Protocol and how we administer it. One of the really important parts in that video is the guidance and how we use that contrast dye to confirm needle placement to make sure the medication gets where it needs to go. Because these viscose supplements, they're gel-like substances. We're all using a lot of hand sanitizer right now. If you've got some Purell and you squirt it out, that's really similar to the consistency of these medications. So because they're thick like that, they can't cross the cellular membrane. So if you're not inside that joint capsule, the medication has no chance of working. So first and foremost, you've got to get the medication where it needs to go. I'll show you how we use video X-ray to do that in just a few slides. But before I get there, what medication you use makes a big difference too, and not just the type of medication, but how frequently you get it. There are a lot of injections that are 1, 2, 3, or 5. As you have more injections, clinical research has shown that it stimulates those synovicytes, those glands, better when you administer a lower dose of hyaluronic acid over and over and over and over instead of just one big mega dose all at once. Think of it like changing the oil versus teaching the car to make its own fresh oil over and over again, so you never need an oil change. And that's why we use primarily Genvisc 850, which is a 5 injection product. And it's got 25 milligrams of hyaluronic acid per injection. It's a higher molecular weight. That 850 stands for 850 Daltons. And clinical research has shown that any medication 750 Daltons or higher has a better clinical outcome than lower molecular weight products. And it's supported in a double-blind clinical research trial that followed patients over a 40-month period, and more than 80% still had a reduction in pain, improvement of function more than 3.5 years later after having the procedure performed. It's also very commonly used over 45 million times in 64 countries without any adverse events or side effects. So we know that Genvisc 850 is very safe. Unlike Hyalgan or soup hearts, it's not from the comb of the rooster. So if you're allergic to chicken eggs or feathers, this is safe. And unlike Synvisc, that is a chemically manufactured product in a laboratory setting, if you've got allergies to latex, vinyl sulfone, formaldehyde, and the other components that they make those chemical-derived products from, this product is all natural and safe. It's from a bacterial culture. And Genvisc 850 does 3 major things. It cushions your joint, lubricates your joint, but most importantly, it binds with the fluid-producing cells inside the joint capsule to stimulate them to start making more synovial fluid and more hyaluronic acid on their own again. This helps the synovial fluid to go from that water-like consistency back into a thick, normal consistency to cushion and lubricate the joint and begin acting like a shock absorber again. Genvisc 850 is also shown not only to be extremely safe, it's actually labeled as safe as saline placebo by the Food and Drug Administration insert in the package for the medication, but it's a very long-lasting product. In that 40-month follow-up research trial against placebo, people that were having these hyaluronic acid injections had a much greater positive result than those who did not. It was lasting for 40 months or longer in the majority of study participants. More good news, viscosupplementation is all natural. It's not a drug. So it can't interact with any other medications you're on. It can't make you sicker or worse because it's an all natural substance already in all of our joints, our fingers, our toes, our knee, our shoulder, our hip. They're all fluid filled capsules that have hyaluronic acid in them inside the synovial fluid. So it's very safe in that regard. Unfortunately, it's not something you take orally or over the counter from a drug food store. It only really works if you administer it inside the joint that's affected. So it has to be injected by a trained medical provider. It's also supported by plentiful clinical research and so safe it's even used as placebo in diabetic research trials. So what's the catch? Especially if you've had viscosupplementation before that didn't work. It's not only what was injected and how many times, but how was it injected? Did you see the injection being performed inside your body? In other words, was an ultrasound or a fluoroscope used to look inside the joint and see the medication actually getting where it needs to go? Now, in our facilities that are certified in the Advanced Arthritis Relief Protocol, we use fluoroscopic guidance. We never guess. We always see inside the joint. And that's because clinical research, such as this from the American Journal of Sports Medicine, shows that without guidance, about 21% of the injections fail to reach the capsule. But with guidance, over 99% do. Now, I'd make the argument that we're 100% accurate because we not only use these video fluoroscopes to see inside the joint and to visualize it and to look at the needle as it approaches, which is this black line here, but we use something called contrast dye that shows up dark on the image. And this one I picked because it looks like the Batman logo. I get a kick out of it. But you can see the dye flowing backwards here and flowing forwards here up behind the patella. That lets us know that we're in the capsule before the medication is administered. And that's why we never miss the spot. Even using ultrasound, you can't see a confirming agent like a contrast to ensure you're in that capsule before the medication goes in. So that's why we use fluoroscopy. which are these video x-ray devices to see inside the knee. And our program is very simple. We follow the research. We do what we think is right. We only accept patients who we think we can help, which is why you're offered a risk-free consultation to evaluate if this might work for you. And the majority of our patients have a significant reduction in pain, improvement of function. This slide says 75%, but that's a little bit of an underestimate. There are very few patients that don't have a positive outcome. We did a randomized clinical trial in 2 of the facilities certified in our protocol in Florida back in 2015. And out of 384 patients in the study, only 1 patient had no improvement. Everybody else had some improvement. And almost 93% of the participants had a 50% or greater reduction of pain, improvement of function. So we know that what we do works very well. And that's because this 3-pronged approach targets each aspect of the disease. The medication, the Genevisc 850, that's injected, increases your joint space hydraulically. It stimulates those synovial to produce more hyaluronic acid and synovial fluid, and stops the friction and the breakdown of the joint. The physical therapy and home exercise we do helps to strengthen the muscles and ligaments and bring that joint back into alignment so that you don't have more damage after you're done with the treatment that makes it come back faster. And the unloading knee brace helps short term to mechanically open that space so that the medication and the exercise can do their job better and not have to constantly be overcoming more grinding and more friction because we're mechanically opening that space during the treatment period. And bracing helps tremendously. This is a bone-on-bone contact knee immediately prior to the application of the brace. This is immediately after the application of the brace here, and you can see the joint space that's been produced. And that draws the medication that's been injected that wants to go to the area of lowest pressure into that compartment to cushion and lubricate it and to make the medication more effective. So if you've had these injections in the past without bracing and it didn't work well for you or it didn't last, this actually really does help the medication work better. Now, here's that bone-on-bone patient I promised to show you. This was an 86-year-old female patient. She was in a wheelchair and a nursing home. She was not a candidate for surgery because of this titanium rod installed from a previous femur break. And I like to show this example because it's the most extreme one we've ever seen in clinical practice. Here's the same knee 2 years later after 2 rounds of injections, bracing, and therapy. Not only did we replenish joint space, but if you remember on the x-ray, the brighter and whiter something is, the more dense it is. Her osteoporosis cleared up. Look at how much more muscle she has. She lost over 60 pounds, and she was walking again. And she was in an independent living facility, no longer in a nursing home. Didn't need a wheelchair or a walker anymore. She had a cane, and she barely used it. She would come into the office. She'd be holding the cane, not walking on the cane. So this is a real patient. I physically saw with my own 2 eyes in a clinic that I co-operated. And she did extremely well with this treatment despite having a really drastically degenerated case. And that's why we offer a risk-free, no-cost consultation to you. We want to see exactly what's going on with your joint, exactly how it's affecting your life, what your goals are. Do you just want to eliminate the pain, or do you want to get back to golfing, dancing, or specific activities? The better we understand your condition and what you're looking to achieve, the more accurate advice we can give you on whether or not this treatment might work and might be right for you. Now, also, if you are bone on bone or you've had this for a period of time or you've tried these injections in the past and they've not been successful, the hyaluronic acid medication is only one tool in our proverbial toolbox. We also have regenerative medicine techniques that we can go to if hyaluronic acid doesn't work. This particular patient right here is from one of our clients' facilities in Western Pennsylvania, just outside Pittsburgh. And that image on the left where that knee is pretty much bone on bone is actually after 5 injections of Hyaluronic. And on that right-hand side is 3 months later, after 3 injections of PRP 1 month apart and 1 injection of amniotic fluid. This was done in early 2017. That particular patient, he was an 88-year-old male, and not only did he have a full reduction of pain, he got back to golfing and other activities he hadn't done in decades. He paid about $6,500 out of pocket to have that done because the stem cell procedure and the PRP wasn't covered by his insurance. Well, insurance is a lot different now than it was 3 years ago. Some of these products are actually covered. Many insurances like Medicare, TRICARE, Blue Cross Blue Shield, Humana, and United will cover amniotic tissue injections if your case is justified for it, if we're able to establish what they call medical necessity. And then other treatments like platelet-rich plasma have become much less costly because the technology to produce it has become more efficient and less costly for the clinicians to purchase and administer. So a PRP injection may only be a few $100s, whereas years ago it was thousands. When it was first done in the early 1990s, I think it was Tiger Woods was the first major US citizen to have it done. A physician came down from Canada to perform it for him. Rumor has it he paid $500,000 to have this procedure done. I don't know whether that's true or not, but PRP is now a little micro fraction of what it used to cost to have done, the average injection being a couple $100. So these procedures, if you need them, if your knee has been so degenerated and your cartilage worn away, are much more accessible, much less costly than they used to be. Now, we look at what's wrong with you during this risk-free consultation, including possibly taking x-rays if you don't already have them. And if you're bone on bone, we know that hyaluronic acid and bracing is probably going to be the best approach for you before we look at using regenerative medicine. Because if you're trying to regenerate your meniscal cartilage and use PRP, there has to be room for that meniscus to regrow. If you're trying to regrow that articular hard cartilage and we want to use mesenchymal stem cells or amniotic fluid products, we need to have some space there first before we administer those products. So oftentimes you can use regenerative medicine in the right way at the right time. And conversely, we've seen it used wrong. For example, if you're bone on bone and you go pay thousands of dollars to have a stem cell procedure done in an orthopedic facility, how do you know those stem cells are going to grow cartilage? Because the way stem cells work is the first thing they do is called homing. They're attracted to cell death and inflammation, what's called apoptosis. So if you're grinding bone on bone and you're growing bone spurs and osteophytes, those stem cells might cause more bone to grow, not cartilage. There's a patient that I was just meeting with this past weekend, and she's had problems with her shoulder, and she's been having stem cell injections over and over and over again, and her shoulder keeps getting worse. Well, why? She went and got an MRI done, and it turns out she had a bone spur there, and that bone spur was rubbing up against her nerves, causing the pain. And every time she had stem cells done, that bone spur grew bigger and bigger and bigger. It actually made the problem worse, right? So part of this risk-free evaluation is not just to look at your condition, but also look at what the best treatment option is both now and long-term, because there's a right and a wrong way to do this. You can use these medications at the wrong time in the wrong way and actually make things worse. Now, PRP, I just want to touch on in detail real quickly. If you've ever cut yourself after the red blood stops flowing, if you've seen that clear or yellowish fluid that comes out and forms the scab, that's your blood plasma. And your blood plasma carries your immune system, it carries your white blood cells, it carries your growth factors. It's the body's ability to heal and recover concentrated in that plasma. When that scab falls off and that new skin is there after your cut has healed, that's from the growth factors in the plasma. So we draw a small amount of your blood, about the same amount you give to do lab testing every year for your primary care doctor. And we concentrate these growth factors in plasma, and then we can inject it into the injury site. And it stimulates collagen, elastin, and fibronectin, all the structures that create the cartilage much faster. It causes these fibroblasts to accumulate, these cells that make those substances. So we can use this to reduce and recover from a meniscal tear or a meniscectomy, where part of your meniscus might have been moved during a surgery if you've gotten worse. So your next step at this point is to schedule your risk-free, no-cost consultation to determine what treatment might be right for you and to possibly get some imaging done, have some x-rays taken if you've not had them done before. So what I'd like to ask you to do at this point in time, if you're interested in scheduling, is just type into the chat box or the Q&A box, yes, your location and how you'd like to be contacted, such as your phone number. And we will call to follow up. I shouldn't say we, somebody from the office will call you after today's presentation to get you scheduled for that risk-free consultation. So just say yes, where you're located, your contact information, and someone will reach out to you and schedule your appointment. Now, before I go on to our questions and answers session, if you do have a question, you can type it in where it says Q&A at the top of the Zoom meeting there. Or if you want to ask your question verbally, you can click the button to raise your hand and we'll unmute you and answer those questions verbally after we get through the written questions. But before I get through the written questions, I'd like to invite one of the practice administrators, Kristen, to speak briefly about some of the safety precautions they've taken and the things they've added to their practice to make it a virus-free zone and safe and free of COVID-19. so that you don't have to worry about transmission of that disease if you go in for your evaluation and your procedure. I also do want to let you know that long before COVID-19 was a thing, when we do these procedures, they have to be done in a clean environment. So we've been sterilizing the equipment, the chair that you sit in while you're having it done. The physician will wear sterile gloves. We'll use an anesthetic like povidone or chloroprep, chlorhexidine to sterilize your skin before the injection takes place. So these facilities have had to been very clean and antimicrobial and antiviral even before COVID-19 was a thing, to keep people from having infections when they have the injections done. And I'm proud to report that despite having hundreds of clinics and having performed probably hundreds of thousands of procedures, we've never had a patient that's had an infection or sepsis or caught something at one of our facilities going back over a decade now. But that being said, I do want to introduce Kristen just to give you a little more information about some of the specific things they're doing to keep you safe during your consultations and treatments at Joint Regeneration and Anti-Aging there in Newnan, Georgia.
Lance, I think we need to go ahead with a question and answer.
Okay.
Kristen,
Well, if Kristen can't be
question.
unmuted to speak.
Lance, I can jump in. This is Barbara.
Oh, okay, Barbara. Hi, thank you.
Hey, you're welcome. Guys, I just wanted to let you know I'm Barbara. I'm the nurse practitioner that does the injections and the exams and kind of talks to you about what we see in preparation of doing what's best for your knees. And I just wanted to let you know about some of the safety things that we have in place in our office, so that, because we know that we're in a very unique time with this COVID-19 virus. We do have a air purification in our office that was created by NASA for the International Space Station. And so we can label our office virus free. It does kill 99.9% of viruses in the air. When we bring you into our office, you sign in at our specific window. We do try as best we can to get you right back to a waiting room that is only for our patients. We keep you socially distanced there in that waiting room, and then we bring you back to the treatment room to have conversations or to do your treatments. Certainly in between every patient, we're wiping down the chairs and the doorknobs and all of those things and using lots of hand sanitizer. So we are, and of course we wear masks. Everyone in the office wears a mask. So we are doing our best to protect our patients and ourselves from any kind of infection from the COVID-19 virus, and as well as flu and any other thing that's floating around this winter. So I just wanted to make that abundantly clear that we have your safety, first and foremost in mind.
Thank you, Barbara. I appreciate that.
You're welcome. Okay, that's all I need to say.
And nationwide, in the over 200 clinics that we've got in our network that have been certified in the Advanced Arthritis Relief Protocol, there's never been a transmission of COVID-19 in any of the facilities to date. So being able to keep them very clean, very safe, and using that specialized air purification and treatment device is really just an extra layer of protection that will actually mitigate the virus in the air and also on hard surfaces. So moving on to the question and answer session, Bill asked, should I have MRI done before the consultation? I've already scheduled to get them. Well, Bill, MRIs don't hurt. MRIs do help us look at soft tissue and fluid, not just the bones. But when we perform the arthrogram with the contrast dye, we're going to be getting a lot of the same information you would get from an MRI and MRI report. So if you're already planning to have them done, your insurance is going to cover it. No harm in having them done. You can bring them with you. But you do not need MRIs to come in for your consultation. We do have the ability to do X-ray and other imaging on site to evaluate and see what's going on and determine whether or not you might be a good candidate for this treatment. So if you've got them, bring them. If not, you can get some X-rays while you're there. If you've had X-ray or MRI done more than a year ago, we would want to repeat it because your disease is degenerative. We want to see what it looks like right now, not necessarily what it's looked like in the past. But if your imaging is 6 months or newer, we can take a look at that and usually make a good determination off of that information. Kathy asks, I had 5 injections in both knees beginning in June. The last injections were July 1st. They used an ultrasound on the first 2, but not in the last 3. That's odd. And how long would it be before you can have other injections? Well, we use guidance on all of the injections. So if you have 5, all 5 will be visualized so we can see where we are going and what we are doing, not just 2 of the 5. And it depends on your insurance, Kathy. So when you call in for your risk-free consultation, give them your insurance information. Aetna, for example, will let you repeat this every 3 months. So you'll be able to come back in at the beginning of October. Medicare and many other insurances require 6 months between injections, but don't let that stop you from coming in, because it's not only the hyaluronic acid injections that we can use. We also have the amniotic fluid injections that might be covered by your insurance and can help to fill where you've had loss of tissue, if you've lost meniscal articular cartilage. And then we've got the really inexpensive and effective platelet-rich plasma injections that can help to regenerate your cartilage, especially your soft meniscal cartilage. So even if you didn't have a full resolution from the last series of injections you recently had, there are some treatments we can do right away that may not only be effective, but also covered by your insurance, so that while you're waiting for October or later in the year to get your next round of injections, you can be doing something to address the symptoms and the pain you're still suffering from. How long do the results of the GenVisc 850 last? Does this procedure have to be repeated after a period of time? Great question. So the FDA labels the medications to last for 6 months or longer. GenVisc 850 has been shown in clinical research to last 40 months or longer. That being said, speaking generally from the thousands of cases I've seen personally, the average patient usually has about 2 to 3 years of pain-free function between injections. I'm on about a 7-year cycle. I had my first series of injections, and the results lasted until about 2013. In the fall of 2013, I had a second round of injections, and I'm at that point now where I'm starting to get some clicking and some popping and cracking, those little noises of crepitation, showing that my osteoarthritis is probably coming back. And with certain activities, I'll get pain and I'll feel that latching sensation. So I'm about due for another round of injections myself. So for me, it's about every 7 years. Average patients usually every 2 to 3, but I've seen people go a decade or longer without their symptoms coming back. A lot of it depends on how bad your knee is when you come in for your evaluation. If you're bone on bone, you're in a walker, you're in a wheelchair, you might need more than 1 round of injections. The results might not last as long because your disease is more progressed. If you're walking under your own power using a cane, you're catching the disease in grade 2 or earlier, your pain may never come back. It might last for the rest of your natural life. So it depends a little bit on how you come in, what stage you're at. That's why we do the risk-free consultation. We look at that to give you better expectations. It's not unlike other diseases like cancer. If you catch it early, survivability rate's really high, likelihood of it coming back really low. If it's more progressed before you figure out you have it, risk is higher, likelihood of it coming back is greater. Osteoarthritis is very similar to that. Kathy asks, I'm still having aching pain in my knees, especially left knee. You're only taking a leave and applying a cold pack. So taking a leave and using a cold pack is actually what's called tried and failed conservative therapy. So what your insurance requires us to document before they'll pay for this, you're already doing a good example of that. And not only can we use the viscosupplementation to increase joint space and help to reduce the symptoms of the osteoarthritis, but especially if you've got any swelling or what they call an effusion, where the joint fills up with inflammatory fluid, we can drain that. We can use anti-inflammatory treatments and not just corticosteroids, things like exosomes, which are an excretion from mesenchymal stem cells that signal to the cytokines and other structures inside the body and tell them to relax and turn off. So it can stop that inflammation process for months at a time. So again, please call in to schedule your risk-free consultation, and they'll go over all the treatment options, not just the hyaluronic acids. The other question, are new x-rays included in the free evaluation? The x-rays themselves are not included in the free portion of the evaluation, but if you have insurance, they will cover the x-rays, will bill it to your insurance at that point. The risk-free consultation is a review of your symptoms and your history, as well as an explanation of what we do, any other questions you might have. And if it looks like you're a candidate and this is something you want to proceed with, that's when we would then take the x-rays and bill that to your insurance if you wanted to proceed. If you don't have insurance, or if you've got a big deductible or something else in the way, the x-rays are very inexpensive. They're only about $45. So even without insurance, the x-ray is very inexpensive if you need it. And even if you don't have insurance, some of the treatments we've discussed today, such as platelet-rich plasma injections, are very inexpensive and might be a good option for you if you're still in that deductible period. So that answers all of the typed questions. I just want to give an opportunity for anybody that didn't type a question, if they want to raise their hand and ask a verbal question over the phone, an opportunity to do that before we adjourn for the day. While I'm waiting for folks to raise their hand there, I just want to repeat that if you want to schedule your risk-free, no-cost consultation, you can either type yes and the best phone number to contact you at in the chat box or the Q&A box, or you can call to schedule your appointment at 770-343-4465, or the clinic directly at 770-683-4495, online at jointregen, R-E-G-E-N, clinic.website, or by email at info@jointregennoonan.com. That's joint, R-E-G-E-N, noonan.com. So any questions anybody would like to ask verbally before we adjourn here for the day? And I thank everybody for your participation. Hope that you learned something new and that maybe you're feeling a little bit better about your options that you have to consider. And again, implore any of you, please take advantage of the risk-free, no-cost consultation. Even if it's a free second or third opinion before you go the surgical route, you'll at least know you exhausted all your options before that point. So yes, do we have a question?
Lance, this is Michael Bannister, and I really appreciate everybody attending the webinar today. And in addition to, if you wanted to fill out the contact for an appointment portion of the in the chat box, we will also be giving y'all a call within the next hour to schedule an appointment with you, because they fill up very fast, and we want to do the best we can for you here in the very short period of time in the very near future. So be expecting a call from us. It'll be probably a 770 or a 440 number, and we surely appreciate you getting on, and we look forward to helping you in the future.
Thanks, Mike. Any last questions before we adjourn today? Had you for about an hour. I appreciate your time. Just want to see if there's any last questions before we adjourn. Looks like still got all the ones in the chat box answered. All right. Well, again, hopefully you learned something new here today, that you've got a little more hope in your heart and your head than you did when you got here, and that you'll act upon that and go in for that risk-free, no-cost evaluation. Thanks again, everybody, for your time. I hope that this treatment works for you just like it worked for me. I'm living proof, 2 decades of mostly pain-free function. I can run around and play tag with my daughter and walk my dog and do activities that I never would be able to do at this point if I went and had that surgery. So this wound up being a life-saving and life-altering and really significant experience for me, and changed the whole trajectory of my life, where I've dedicated the rest of it to sharing this information with more people like you here today and helping clinics learn how to offer these really effective non-surgical treatment alternatives that are covered by most insurances, including Medicare. So again, thank you for your time. Please schedule your risk-free consultation. Even when we close this down, the chat box and Q&A box will be open for a few minutes. So you can type yes, put your contact information in there, keep an eye out for those phone calls from us, and look forward to seeing you all in your consultations, and hope that this works for you just as it did for me. Thank you and have a great day.